Hello, I'm Dr. Bob Trestman, and I'm going to be presenting today on managing problematic behaviors. Joining me in this presentation is Dr. Bonnie Hennig-Trestman. She'll be introducing herself later this morning. I am professor of psychiatry at the Virginia Tech Carilion School of Medicine and chair of psychiatry at Carilion Clinic as well. So let's dive in. Many of the symptoms that people with Huntington's disease experience may alter or impair their self-awareness, their emotions, and their behavior. Two approaches to reduce these symptoms include both the use of psychiatric medication as well as behavior modification. We'll review the different types of medications that might be used, the potential benefits and the risks of them, and we'll also review different behavioral approaches to address each of the different domains of behavioral problems. It's first important to recognize that behavioral symptoms are quite common in Huntington's disease. Indeed, about 90% of all patients who are symptomatic will have problems with sleep disorders of one kind or another. 70% of people will experience apathy to a greater or lesser extent. 50% will have problems with their mood, with depression or anxiety or both, as well as issues of agitation and aggression at times. This can be incorporated into part of disinhibition, impulse control problems, as well as potentially issues of misinterpreting reality with delusions, suspiciousness, or paranoia. We'll go into each of these areas in turn now. First, in general, how do we think about behavioral changes and how do we assess them? Initially, it's important to think about what are the other medical or psychiatric issues. And so it's important to review each of these with your treatment team to be sure that nothing is being overlooked. It's also important to review all of the medications that someone may be taking, because some of the medications themselves may cause side effects. It's also important to look at what is the daily schedule and whether or not there have been recent changes to it that might contribute to some of the problems. As the treatment team is working with you, the patient as well as the family, it's important to get information from all affected participants. And it can be a challenge. From the patient's perspective, he or she may choose to minimize their behavior because they may not even be aware of it. And that's something that Dr. Hennig-Trestman will speak about later on in this presentation. Further, family members frequently feel like they're walking on eggshells and they don't want to upset their loved one. And so getting this information about all of the challenges that are genuinely being experienced can be difficult. The first choice, as I've mentioned, is to work with both the patient and the family. Once the assessment is made, to intervene into what are the behavioral problems and how to fix them. Many times we can't change the person's behaviors themselves, and that's an important characteristic, that even though the behaviors may not be directly changeable by that individual, we can learn how we react as family members, as treatment team givers, as caregivers to those behaviors. And in turn, our interaction with the individual whose behaviors are problematic can in turn change. When and if medication is required, it's important to recognize that what we're treating is an illness that evolves. And so the symptoms and stage of the disease needs to be considered. And medications, therefore, need to be reassessed on a regular basis to be sure both that they're working and that any side effects that may occur are being minimized. Let's move to the first domain of problematic behaviors that arise in Huntington's disease. The first are sleep disturbances. And sleep disturbances or insomnia can include challenges of both falling asleep as well as difficulties staying asleep. What can cause it? Many, many things can cause sleep disturbances. First, there can be other medical or psychiatric conditions that can contribute to this. feeling pain or discomfort. That during the day, people may not be aware of the pain because they're being distracted. At night, people tend to be more aware of pain when they're not being distracted by anything else. And so it may become more of an issue at night. Medication side effects may be making it difficult for people to sleep. The use of alcohol, caffeine, or other drugs may also contribute to problems sleeping. And sleep hygiene, staying up late, watching movies or videos, surfing the web, as well as taking naps during the day. Too many of those naps or too late in the day may also contribute to difficulties with regular sleep. So what are the behavioral changes we can recommend? Well, certainly if there are issues with alcohol, with nicotine, with caffeine or other drugs, addiction counseling and support for those problems can be of enormous value. And this may be an appropriate time to raise those issues. Additionally, addressing all the problems with sleep hygiene would be very much appropriate. All of those should be addressed before we start looking into the use of medications as a way of addressing these problems. What are the medications? Well, melatonin may be an appropriate medication. Melatonin is a brain chemical that is naturally synthesized, but it can also be administered just as a pill. It's useful particularly when there are sleep-wake cycle disturbances or circadian rhythm disturbances. These typically occur, and they're most obvious when someone would routinely fall asleep at 2 or 3 in the morning and then wake up at 1 or 2 in the afternoon. They're off the normal cycle. And because of that, melatonin, when administered, may help to bring people back into a normal cycle of circadian rhythm or biological rhythm. Other sedating medications may certainly be of some use. Antidepressants may also help in this, and antipsychotic medications may help to sedate and allow people to have a good night's sleep. One thing to be clear about is that the use of medications like benzodiazepines are generally discouraged. The problem with benzodiazepines is that they accumulate in the body. They can cause problems concentrating. They can make it difficult for people to find words. They may make it difficult for people to have appropriate respiratory drive, which is the fancy way of just saying remembering to breathe. And in combination with lots of other medications, benzodiazepines can reduce that respiratory drive and put people at risk for dying because they're not breathing adequately. The next topic that we wanted to address is apathy. We hear about the term a lot, but frequently we're not really even aware of all the different elements that can contribute to apathy as we think of it medically. There are 3 different domains of symptoms in apathy. There are emotional or affective symptoms, there are behavioral symptoms, and there are thinking or cognitive symptoms. The affective symptoms are most obvious in terms of emotional blunting, where people have very restricted emotional experience and they don't tend to express it very much. Their face looks very flat or blunted, and they don't display emotion very much at all. There can be a loss of empathy or connection with other people, and there can be an apparent indifference to what's going on in the world around them. Behaviorally, this can become obvious in terms of social withdrawal. It can be obvious also in terms of a real loss of self-initiated behavior and a lack of self or spontaneous conversation on their part. Therefore, it requires others to stimulate or prompt people who have apathy to start a conversation or to engage in normal activities of daily living. And there can be poor persistence. They may not finish activities they start. They may just drift away from one area because of a problem in concentrating and staying focused. So The cognitive aspects include a lack of interest in routine or novel activities, and difficulty planning and implementing actions that are goal-oriented. Further and simply, there is a reduction in a normal level of curiosity. All of those are aspects of apathy. Apathy can frequently look a lot like depression, but they are distinct in a lot of critical ways. Depression in this diagram can clearly be seen to include a lot of different symptoms, typically and most commonly sadness or a depressed mood, a sense of hopelessness, guilt and self-criticism, suicidal thoughts or behaviors. Vegetative symptoms, those symptoms which can be difficulty with appetite, with sleep, and so forth. Those are characteristic of depression. But depression shares symptoms with apathy as well. A decrease in interest, in energy, in self-awareness or insight, as well as reduced physical behavior, or what's called psychomotor retardation. So it's important to recognize that both apathy can exist, depression can exist, and the symptoms can overlap. So that's why we can sometimes confuse the two problems, but they each need to be thought of and addressed. So what are the recommendations for treating apathy? One critical behavioral recommendation is to provide daily structure and to provide consistent encouragement regarding social and physical activities. With that kind of structure and support, people will frequently be able to be engaged, become active, become more responsive. And so it's important to provide consistency from the caregiver perspective. In addition to and separate from that, if the behavioral interventions are not enough by themselves, then we can consider pharmacology or medication. The first thing is to be aware that some other medications being prescribed for other symptoms may contribute to apathy. And so it's important to review with the treatment team what those medications might be and whether any of those might be contributing. And if so, can any of the doses be reduced or the medications eliminated completely? Further, because depression may coexist with apathy, it's very important to treat any ongoing depression as well, because that will also address those overlapping symptoms. And we'll talk more about depression itself in just a minute. Additionally, even if someone does not have a formal depression diagnosis, using an antidepressant may help with those symptoms that are part of apathy that overlap with depression. And there are some times when the treatment team and the prescriber may recommend certain stimulating antidepressants or actual stimulating medications. These stimulants can frequently be used to treat attention deficit hyperactivity disorder, and they can indeed work to address some of the challenges of apathy. It's important, however, to be aware that many of these medications that can be stimulating can also worsen irritability. They can worsen sleep disturbances. So it's important to take this risk into account with the treatment team in the decision-making as to whether or not these medications will overall benefit the patient suffering with apathy. Now let's focus more specifically on mood changes. And this covers a wide array. It includes anxiety, it includes depression, it can also include agitation and aggression. And within that context of aggression and agitation, that's usually driven by either problems of being disinhibited, being very impulsive, having an impulse control problem. And it may also be that there are problems of perceptions being distorted, where people may actually have delusions or suspiciousness that can be actually at the level of paranoia. And we'll talk about that in turn. So what about anxiety? Anxiety is normal. All of us can feel anxious. That's a part of being alive. However, when it becomes so significant that it impairs our ability to function, it's important to recognize that it is something we can treat. Further, when it becomes really severe, people can also have obsessions, which are persistent, intrusive thoughts, or compulsive behaviors. Compulsions are repetitive behaviors, whether it's hand washing or checking of different things, whether the door is locked or other things of that nature. Further, people can actually have panic attacks. Panic attacks are when people feel as though they are literally having a heart attack, or it feels like they are dying. And panic attacks can bring people into the emergency room, and it's one of the biggest reasons that people in the emergency room will go through a whole protocol to rule out a heart attack, to be sure it is severe anxiety in the form of a panic attack. Can we treat it? Yes, of course we can. Pharmacologically, antidepressants are actually the preferred option, and we've worked in research and in clinical care for the last 30 years, and it's quite clear that the treatment of choice for really severe anxiety that won't respond to other basic structure and reassurance for milder forms are antidepressants. And if the first antidepressant that's chosen is ineffective, alternate antidepressants can certainly be chosen. It can also be a switch based on the treatment team's recommendation if the side effects of the first antidepressant chosen are problematic. Other antidepressants may have very different side effects. Furthermore, we sometimes use antipsychotic medication to treat anxiety. And that can be a particular note for people with Huntington's disease, because we can also effectively use many antipsychotic medications for treating the movement disorder or the chorea of Huntington's disease. Now let's talk about depression. I've already gone through some of these symptoms, but it's really important to emphasize these because depression, as I've noted, can occur in many patients with Huntington's disease. They can range from mild to severe, and any or all of these symptoms can exist. Certainly feeling sad or down, but not just in the way that many of us might feel sad or down in response to a given situation, but persisting for weeks on end. Having a loss of interest in activities, having appetite changes, either a weight gain from eating too much or a weight loss from losing an appetite and not eating at all. Again, sleep problems, typically not being able to stay asleep or waking up early. A loss of energy or chronic fatigue is common in depression. Feeling worthless, feeling guilty or hopeless can be very much a part of depression, very distinct from any issue of a diagnosis of Huntington's disease. As we all recognize, people with the illness can nevertheless be very hopeful about the experiences in their life and the potential for leading a full life, full of richness and joy. It can also include difficulty thinking, as well as suicidal thoughts that can range from being passive thoughts, for example, hoping that they don't wake up tomorrow, or all the way through to very active thoughts of planning what they might do to kill themselves. All of these are part and parcel of the syndrome of major depression, and this is treatable. We can address this. We can help to treat it. Generally, for severe depressions, medications are recommended. And the most commonly used medication to treat severe depression is an SSRI antidepressant. An SSRI stands for a selective serotonin reuptake inhibitor. And that's obviously why we typically call them SSRIs. It's a mouthful. What they do, all of them as a group of medications, target the brain chemical serotonin. Serotonin is a brain chemical that's a messenger in the brain, from one part of the brain to another. And in many people with depression, there's an inadequate functioning of the serotonin system in the brain. And using an SSRI antidepressant has been found to increase the availability of serotonin and help people's brains to function normally. And it can eliminate or at least reduce significantly the symptoms of depression and allow people to function very well. And as I've mentioned, if the first antidepressant is ineffective or has side effects that are not tolerated, there are many other alternatives that we can choose. Now let's move away from those core traditional mood symptoms of anxiety and depression to agitation and aggression. These can be extremely problematic in helping manage some of the problematic behaviors that occur in patients with Huntington's disease. And this can include difficulty with regulating your emotions. It can be explosive events where emotions are really out of control, which can then in turn lead to physical aggression or verbal hostility with shouting, swearing, or a range of threats. One of the challenges for all of us to remember is this is the disease talking. This isn't the person. This is a challenge, and an overwhelming challenge at times, it seems, for caregivers, because it's important when you've lived with, cared for, loved this individual, and they behave in this way, it can be so very difficult. So it's important to recognize as you are working to cope with these problems, this is the illness. This isn't the person. So disinhibition is a fancy way of saying an impulse control problem where people act without thinking. There's a difficulty in controlling any sudden urge, whether it's inappropriate behaviors, hurtful behaviors, or very risky behaviors, reckless spending, shoplifting, or other things that could get people arrested if they are caught by the police. Part of the contributing factor that underlies this, again, as this brain disease is affecting the multiple parts of the brain, people may no longer experience the core emotions that many of us experience: shame, embarrassment, or fear. Those socializing emotions are critical. They can keep us from doing things that are wrong. They keep society functioning. They keep us from stealing, from making rude comments, from participating in or engaging in self-destructive behaviors. And so a lot of those normal limiting factors are eliminated. And because of that, people express these behaviors, and they seem and indeed may be out of control. This is a real challenge and something that we can help. Additionally, there can be distortions of perception. What we perceive, what we believe, and how we interpret the world around us is a very complex set of brain-based biologies as well as behaviors. And so the common misinterpretations, the delusions, are believing things when there are no facts to support them. Typically, it may be that someone believes that their significant other, their spouse is having an affair, that people might be out to get them, that people are spying on them. And this can also be very problematic, and it's extremely hard because you can't simply convince someone that it's not true. It's very, very difficult to manage. And so how do we understand these problems? Well, again, first we have to understand what's causing it. Sometimes it's other treatable medical or psychiatric conditions. It might be side effects of medications that are being used to treat other conditions or being used to treat Huntington's disease. The treatment team needs to evaluate those closely. Again, any Alcohol or drug use, caffeine, nicotine, all of these may be contributing to some of the potential problems. Sleep deprivation can lead to a lot of these problems with agitation. Someone who is overstimulated, we need to be very thoughtful about not allowing the environment to be one that's overstimulating for individuals with Huntington's disease. Or there may be unmet biological needs. There may be hunger that people with more advanced illness may be unable to directly speak about or recognize. Body temperature irregularities. They may be too hot or too cold. And fear. Fear can drive a lot. And so it's important to help create an environment where people feel that it's a predictable environment, it's a safe environment. Pharmacologically, there are many things that we can do to help. For severe or sudden outbursts, antipsychotic medications can be very effective to help to reduce or eliminate these severe or outburst aggressive behaviors. For chronic agitation and irritability that becomes extremely impairing to normal daily functioning, a chronic use of an antipsychotic medication, or what are called mood stabilizing anti-seizure or anticonvulsant medications can work very well. But those need to be taken for this purpose on a chronic, everyday basis. And for those at later stages or end stages of Huntington's disease who may be unable to effectively communicate verbally, pain medications may be used, but they need to be monitored carefully by medical staff. So typically these would only be used in inpatient settings, in a long-term care facility, or in hospice settings. So with that, let me transition to Dr. Bonnie Hennig-Trestman.
Thank you, Dr. Trestman. I'm Dr. Bonnie Hennig-Trestman, also known as Dr. Bonnie. For this part of the presentation, I'm going to focus on the behavioral recommendations for mood changes. So the question is, why is it so hard to change the behavior of somebody with Huntington's disease? And the answer is a term called anosognosia. Anosognosia is what I consider the invisible symptom of Huntington's disease. It's a Latin term for lack of knowing oneself. It's caused by alternate functioning in certain brain regions that constantly monitor how we act and behave. Think of it as the temporary effect of alcohol use, where the brain is temporarily knocked out. An example of this can be illustrated in somebody who's had too much to drink. Some people fail to recognize their own uncontrollable movements. So, for example, when a law enforcement person pulls somebody over who's been drinking and driving, and they have them get out and do a sobriety test, meaning to walk a line heel toe, the person's brain is telling them that they're doing this, but their body is showing something very different. In addition, some people fail to recognize that their behavior is inappropriate. Again, if we use that example of somebody who's been drinking and they're at a party, sometimes they're talking too loud or talking too slow, but they don't realize this. Some people even fail to recognize that their thinking process has been altered. Again, if we go back to this illustration, this one example, if somebody feels that they can drive, they say, give me the keys, I can drive. They're not really thinking clearly, but their body is doing something very different than what their brain is perceiving. And it's really important to remember that the person with HD usually isn't acting out on purpose. Many times they can't help it or they can't stop the behavior. So what can family members do? There's a few things. Try to avoid stressful situations. Don't get upset or yell at the person. Try to stay calm and to use a gentle voice. Don't try to argue or reason with the person. Definitely avoid physical contact with the person. And if needed, leave the room or the house. You can also be proactive. You can teach family and friends about HD so they know to expect some of these behaviors. Keep routines and daily schedules because people do better when they know what to expect. And create a good working relationship with the HD team. Contact the team when needed and tell the person with HD you're contacting them. So many times I get people picking up the phone and calling me saying that there's a behavioral problem, but then they say, please don't tell the person with HD, my loved one, that I've called you, which makes it really difficult because I can't help at that situation. But what you can certainly do is to tell the person with HD, we've discussed this, and I feel that you're out of control, and I need to contact the Huntington's disease team. So you can either be on the call with me, or I'm going to call them by myself. There are some things that you can do to try to avoid. Try not to be too rigid or too controlling. Try not to be overly demanding or critical. Try not to get angry if the person with HD forgets. And please do not be physically or verbally aggressive. There are things you can do to try to change behavioral problems as well. Give 1 day in advance notice for any changes. Keep that consistent routine. Try to distract the person with HD. Give the person with HD as much control as possible. Many times behavioral issues are because the person feels out of control. And give the person with HD real choices. For example, you can say, here are 2 movies. Which one do you want? Or your appointment with the doctor is coming up tomorrow. Who do you want to go with you, me or this other person? Here are some more recommendations as well. Maintain realistic expectations of what the person with HD can do. Avoid confrontation and avoid correcting the person. Be calm and gentle. Try to focus on positive behaviors and focus on the things that they can do. Be consistent. Remember, if the person with HD knows that eventually you're going to give in, then what you're teaching them is to be aggressive. It's really helpful to create family rules and let the person with HD know these rules ahead of time, including when to call 911. It's helpful to do this with a healthcare professional, and I do this in my office with people all the time. I basically say to people, if you're out of control, then what we're going to do is to have your loved one pick up the phone and call 911. She's not or he's not going to use that as a threat. For example, saying, if you don't calm down, I'm going to call 911. If the person is out of control, then it's very important to be able to do that. And please remember safety first. If you are or feel threatened, scared, or abused, get yourself away and call 911. So in terms of caregivers, there are many things that caregivers need to know. First, caregivers are people who need taken care of as well. Know that caregiver burden can lead to psychological stress, depression, anxiety, and can affect your immune system and increase your blood pressure. Here's some things caregivers need to know. First, it's difficult when you don't feel appreciated and your loved one doesn't say thank you enough. It's also okay to want to have a life even if the person with HD remains at home. And it's a very hard job to do, especially when the person with HD is negative, self-centered, or even abusive. So here are some caregiver tips. As caregivers, you need to find a place to recharge your battery and for respite. That could be finding a good support person or a therapist you can talk to. You can also join a caregiver support group. Take personal time for yourself, such as meditate, read a book, take a yoga class. There are many free apps that you can download. Go for a walk. Make sure you get enough sleep. Eat clean and drink water. And have regular health checkups for yourself. So here are some final thoughts from Drs. Bonnie and Bob. Remember that symptoms of Huntington's disease, including mood changes, are the disease, not the person. Find a team of healthcare professionals and work closely with them. Have open communication between the person with HD, the family, and the healthcare team. Know that medication might not work right away. Ask your provider what to expect from the medication, including when will you see a change and what are the common side effects. Unless there are unbearable or critical side effects, try to stay on the medication for at least 6 weeks. The people impacted by Huntington include you, your family, and your loved one with HD. Everyone is equally important. If you take care of yourself, then you can better take care of the person with HD. We hope you found this presentation helpful, and we really appreciate your time. Thank you.